A very good day, ladies and gentlemen. This is Dr. Tan here. Welcome back to the Medical Saga YouTube channel. Today, we are going to learn about case-based discussion. Before I deep dive into the video lectures on case-based discussions, allow me to disclose that the reason why I prepare these case-based discussion video lectures is to allow our fellow house officers to have a better understanding on how a case-based discussion is usually or normally conducted. This slide illustrates to you the content of the video lecture today. First and foremost, I would like to explain to you the purpose of doing a case-based discussion. Following that, I'll explain to you each of the components in the case-based discussion. After that, we'll spend some time to learn about medical history delivery, which is the crux of a case-based discussion. Last but not least, we will spend the last few slides to discuss about how to formulate the diagnosis, how to formulate investigations, and also how to formulate a management plan for our patients in the case-based discussion. Let's begin the lecture by first understanding what a case-based discussion is. For the benefits of the audience who have never been introduced on what a case-based discussion assessment would be like, is actually a formal assessment that will be conducted through a formal discussion of a clinical case that would be followed by a feedback as well as a scoring using a structured assessment form. Later on, we are going to move into the nitty-gritty on the feedback form as well as the scoring system. But before that, let us understand that case-based discussions is actually one of the most commonly used assessment tools in our medical career. As illustrated here, you can see that case-based discussion is actually one of the assessment methods that will be used across a spectrum of clinical assessment, from medical student to house officers and even to master student registrar or even to a subspecialist trainee. With that, I hope that I can have your attention in the subsequent session because case-based discussion is actually one of the most important assessment methods in your clinical career. So moving on, allow me to share with you the summary or the main components of case-based discussions. So in the usual manners, a case-based discussion will always begin with formal presentations of a clinical case. And the clinical case could be either selected by the clinical assessors or by the candidate himself. So what are the areas that you will be assessed during the presentations? So you would be actually assessed on your presentation technique or your delivery style, and also the completeness of history. And also equally important, we'll see whether are you confident with the case, and also last but not the least important is that the accuracy of the information provided by you will be critically appraised. After case-based discussions, the clinical assessor will move on to the case discussions. So here I'm just giving you some bullet points about what will be discussed during the case-based discussion because later on I'm going to dissect each of these components in details. So during case discussions, normally we'll discuss on the differential diagnosis and also discuss about how did you come to the provisional diagnosis and also the list of differential diagnoses that have been offered by you. Sometimes we may also discuss about some topics related to the diagnosis. Sometimes we may also discuss about the social history of the patients. But ultimately, we are trying to check your understandings of that particular case. After that, we will normally discuss with you about the investigations and we'll end it with the management of the case. Of course, at the end of the case-based discussion is always a feedback or evaluation. We're going to tell you about your strengths and also most important is about areas for your improvement. So in summary, a house officer case-based discussion components will consist of history taking, investigations, management, communications, and also documentations. After understanding the components in the case-based discussions, now let's switch gear and take a deeper look into each of these components. Firstly, let's take a look at the case presentation components. Personally, I consider case presentation is the most important section because for the case presentation itself, not only you give the first impression to examiner, but most importantly, that will affect or that will influence how you formulate your investigations and management subsequently. Hence, I'll encourage all the medical students and house officers to spend time to practice on how to get a thorough history, not only for assessment but also for your own learning purpose. Overall, this will be the template or the structures that will be used during the case presentations. So during the clerking, you are actually mandated to clerk the history of presenting illness. In short, we call it HOPI. And during the HOPI, you need to elaborate on the chief complaints and tell us what about the other symptoms, the comorbidities, and also it's a mandate for you to take further history on the patient's past medical history, the past surgical history, family history, allergy history, and also social history. Of course, there will always be some variations in terms of, what history will you focus more on. All of this would actually depend on the cases that you have selected. Nonetheless, this will be the most basic template that will be used during a case clerking. Next, I would like to dedicate this slide to emphasize or to stress on the importance of getting the patient's chief complaint or getting the history of presenting illness correct. By definitions, chief complaints or HOPI refers to a patient's self-reported primary reasons when they present to the medical care. Following the identifications of a patient chief complaint, the next most important thing to do is to elaborate or to expound on the chief complaint. So allow me to share with you one of the commonest acronym that being used in practice or in your examination is this mnemonic known as Socrates. In short, it stands for site, onset, radiation, associated symptoms, timing, exacerbation or relieving factors, and also the severity of the chief complaint. In practice, after identifications of the chief complaints, especially after a detailed history on the chief complaint, as well as establishments of the other associated symptoms, most of the time clinicians can be quite certain with the diagnosis of that particular case. But I must emphasize that in complex cases, it may not be so straightforward because sometimes the chief complaint can be just a red herring. Hence, it's still important for you to take a detailed history, especially emphasizing on how to refute the other differential diagnosis. In this slide, I would like to highlight on a certain part of history that tend to be overlooked by the junior doctors. So firstly, it will be the compliance to medications. It is imperative for the treating doctor to check on the compliance medication because our patients are humans too. Sometimes they may have challenges. They may have difficulty in taking the medication on a daily basis. So as a clinicians, we really have to explore on that and try to come up with a plan that the patients can comply to. So that brings us to the second point, which is the reason for readmissions or admissions. So let's talk about reasons for readmissions. A lot of times, I couldn't say it's a lot of times. Sometimes it can be related to the compliance to medication. Sometimes it may not be. Even the patient fully compliant with medication, sometimes the disease may just progress. But however, if you spend time to find out the reason of readmissions, most of the time we can try to optimize the patient's care during that particular admissions and ultimately prevent the unnecessary readmissions next time. So last but not least, we also want to understand our patient wishes and beliefs because in today's modern medicine, we talk about shared care. Like 50% care comes from the clinicians and another 50% of care comes from the patient self-care. So we need to understand our patient as a whole and try to empower them so that they can take care of themselves, not only in terms of compliance to medication, but as well as leading a healthy and active lifestyle. So next, in the next few slides, we're going to talk about how to formulate the differential diagnosis. In the regard on how to formulate a differential diagnosis for your case, I would like to take a case of acute chest pain with shortness of breath as an example. So a lot of time as practicing doctors, how do we come up with a professional diagnosis? It actually has to do with your clinical experience, but for the junior doctors, a lot of time we will have a list of differential diagnosis, and bear in mind that it's always common things come first. But we must always have a differential diagnosis of those life-threatening causes which we cannot miss because you miss the diagnosis, especially it is a time-sensitive diagnosis. It will lead to a very unfavorable outcome for our patients. So now let's come back to the formulations of the differential diagnosis. Now let's come back to this case of acute chest pain with shortness of breath.
I believe in practice, off the top of our head, we will definitely consider acute coronary syndrome as our provisional diagnosis. But the most important part is that how do we support our suspicions of acute coronary syndromes is actually through history taking. So from the history, you will of course first take an open-ended history. You will let the patient tell you what the chief complaint. And after that, you may zoom in. You may try to filter the history, or you try to ask a more targeted history. Say if the patient did not offer you a very suggestive histories, we will try to ask targeted history. For example, you ask about where is the chest pain? Is it central, retrosternal, or left-sided? And what's the nature of the chest pain? As we know, ACS, most of the time the chest pain will be crushing in nature, as opposed to your other causes of chest pain like pruritic chest pain or your musculoskeletal chest pain. And a lot of time, ACL is also associated with radiation pain. It may radiate to the neck, jaw, or your left upper limbs, and they will have autonomic symptoms like profuse sweating, palpitation, giddiness, nausea, vomiting. Sometimes they may also complain of syncope or pre-syncope during the chest pain. If the patient has a pre-existing ischemic heart disease or pre-existing coronary artery disease, they may tell you that the GTN actually helped in terms of the relief of the chest pain. Hence, I hope you understand that to come up with a sensible provisional diagnosis, you need to have some understanding on the typical presentations of the particular pathology, like in this case, ACS. Next, I would like to talk about another spectrum of the clinical presentations, which are the small group of patients who sometimes may present with atypical symptoms. In this regard, I'm talking about patients who suffer from acute coronary syndrome, but they did not present with the typical symptoms that I have just mentioned to you earlier. So this is particularly common amongst our women populations, or sometimes among our patients with chronic long-standing diabetes mellitus. When they have ACS, they may just present with syncope, vomiting, sometimes just epigastric discomfort, and hence we need more clinical experience. And a lot of time in patients with this kind of presentation, right, we need blood investigation, we need also an ECG to help us to establish our diagnosis. But nonetheless, in the history taking, we always ask about risk factors of our patients, like in order for us to risk stratify them. I mean, of course, patients with the risk factors, they are more likely to develop ACS, but sometimes they may also present ACS without any known risk factors. So that can be discussed in another sections. But nonetheless, so when you have a patient that you suspect ACS, right, you always ask, the patient got diabetes mellitus, hypertension, dyslipidemia, is it a patient a smoker or not? And also by genders, male will have a higher risk of developing ACS. In the previous slide, we have discussed about one of the provisional diagnoses in patients with acute chest pain with shortness of breath, which is acute coronary syndromes. So now let's talk about how do we formulate or how do we provide a list of sensible differential diagnoses during a case-based discussions. So in this presentation, I just try to gear it towards how to present your case or how to present your differential diagnosis during a case-based discussion, because in clinical practice we are a little bit different because we tend to be more practical that have to do with your clinical judgment as well as your clinical experience on the whole. But anyway, in patients with acute chest pain with shortness of breath, I think the differential diagnosis that should come up during a case-based discussion would always be these top four, because these top four diagnoses are life-threatening. They are actually time-sensitive because if you delay the treatment, it can lead to unfavorable outcomes. For instance, would be acute coronary syndromes, acute pulmonary embolism, aortic dissections, and pericarditis. So how do we differentiate all these four pathology? A lot of time is from your detailed history taking as well as trying to understand the disease itself. For instance, in patients with acute pulmonary embolisms, they may come with typical pruritic chest pain, and most of the time they will be tachycardic, and sometimes they may have hemolysis. If they have really have a significant pulmonary influx, they may have hemolysis. And also most of the time they may have risk factors, for instance like immobilizations. They may have a recent COVID-19 infections, or they may be taking some medication that's pro-thrombotics like your estrogens containing contraceptive pills. On the other hand, for aortic dissections, most of the time they may present with a typical piercing chest pain. They radiate to the back. The list of differential diagnoses here may seem intimidating to those who are uninitiated, But trust me, the purpose of having a case-based discussions is just to ensure you have a sound understandings on the history as well as the presentation of each of these pathologies. Most of the time, we just expect you to provide us a few sensible differential diagnosis, because we understand that in practice, most of the time, after you got the history right, you can be actually quite certain with the provisional diagnosis, which you will further confirm with your physical examinations or your the blood investigations or your other investigations. But I think for the status, as well for the junior doctors, we really need to make sure that you always have a sensible list of differential diagnosis. And most importantly, I can assure you that we will always discuss about life-threatening causes, because those are the diagnoses that we cannot miss. Like for example, like ACS, like your STEMI or non-STEMI or your unstable angina, your acute pulmonary embolisms, aortic dissections, or sometimes maybe pericarditis. So how do we achieve that? It's always go back to basics on your history takings, not only to support your provisional diagnosis as well as to review other differential diagnosis. As an exercise for you, I would like to urge you to spend a few seconds to read about this slide and try to come out with a differential diagnosis in a patient presenting with fever, with vomiting, or diarrhea. Also, using the same template that I provided you earlier, try to formulate the differential diagnosis for the patient presenting with fever, with cough. Moving on now, let's pivot to another aspect of the discussions, which is about investigations. So when we come to the investigations discussions, what we want to check is that we want to know whether you have a sound understanding on the indications or on the clinical implications of each of these investigations or on each of these tests. Because in practice, we need to understand that most investigations need to have a justification, because our resources are finite. We cannot order A to Z tests for every patient. Hence, all the tests that we order need to be justified. My next take-home message for the junior doctors when it comes to clinical investigations will be trying to organize the investigations. For instance, when I talk about investigations that we would like to order, we'll talk about blood investigation first. For example, like your full blood count, renal profile, liver function test, and so on. And after that, we'll talk about microbiological investigation if it's deemed necessary. After that, we'll talk about imaging investigations if it's needed. Of course, there will be other investigations that doesn't or that do not fit into the above categorizations. I will label it as others, like your UFAM or urine PCR, or your endoscopic assessment like OGDS or colonoscope. But nonetheless, always try to categorize your tests, because it will not only help you to organize your thoughts for the examiners, we can also follow your thought process much more clearly. Of course, as you advance in your career, sometimes the presentation style might actually vary slightly, but the gist of the discussion will remain the same. If you are going for your PACES or going for your professional examination, a lot of time we tend to say the confirmatory test first. But I think there's no right or wrong way of presentation style during a case-based discussion, but I think ultimately it must appear organized. To give you an understanding on how do we rationalize our investigations, we would like to share with you a case of symptomatic ascites due to decompensated liver cirrhosis. Let's start with blood investigation first. As you can see here, there will be actually a few tests that we'll consider, ranging from full blood count, renal profile, coagulation profile, liver function test, CRP, viral screening, tuber markers, and blood CNS. So each of these tests would have clinical implications. Let's start off with full blood count first. So why do we order full blood count? Because you want to look at the HB counts. Is the patient anemic? But bear in mind with me that anemia can be diagnosed from physical examinations. If the patients appear pale to us, most of the time they are anemic, especially in the background that patients have a liver cirrhosis, isn't it? So being tested, a lot of time we still have to emphasize on our history takings as well as the physical examinations. So moving on, we also like to look at the platelet counts. So why is it important? Because thrombocytopenia is associated with liver cirrhosis. So another reason is that platelet count is actually a parameters of liver synthetic functions. So a lot of time in patients with moderate to advanced liver cirrhosis, the platelet count will drop. Another parameters we'll look at in full blood count will be the total white cells. We'll look for leukocytosis, which may suggest ongoing infections. And of course, there will be a differential count for the total white cells. It's a bacterial infection, most of the time you'll be having a neutrophil as well, means a neutrophil's predominance in that case. So when you tie together, right, if the patient got leukocytosis and a patient has symptomatic ascites due to decomp liver cirrhosis, you may wonder, could the patient have spontaneous bacterial peritonitis or not? So next test will be the renal profile. I think is one of the essential tests that we would order for most of our patients. That in this case, because patient got liver cirrhosis, you want to see whether is there anything to suggest, occult or overt GI bleed? Because if the urea and creatinine are disproportionate rates, you always suggest that could the patient have upper GI bleed? And also you want to establish the patient's renal functions, and a lot of medications might need to be adjusted if the patients have a baseline deranged renal function test. And also calculation profile, because you want to use that to calculate a Chopper score, and also again it's a marker of liver synthetic functions. I think the rest of the test I'm not going to explain to you because I already put on the explanations beside this test, but this will be the general ideas when we are ordering blood tests. We will ask you what the reasoning, because all these tests somebody has to pay for it, either patients or whatever the hospital has to pay for this test. So every test that we order must have reasons behind it. So other tests that we may consider will be the imaging tests. I think here are the different tests that we may consider. But bear in mind that we will not order all these tests in patients with symptomatic ascites, because ultimately it depends on clinical judgments. For example, CT liver phase, we don't do that for every patient because we will always start off with a less invasive or less costly test first. For example, we will do an ultrasound of the HBS to see if there any sonographic features suggestive of HCC, and also to couple with that, we order tumor markers, like I mentioned in the previous slide, the alpha fetoproteins. If both the tests are suggestive or either one of the tests is suggestive, only then we'll proceed with a CT liver phase, because CT scan is not without risk. They have the ionization risk and also the contrast risk and so on. But nonetheless, I think we will always start from the basic test first. As the clinical conditions requires, we may only move on to more advanced tests. I would like to end the presentation on investigation by urging you to read more about peritoneal fluid analysis, and also to read about the SAAG as mentioned here, the serum acetic albumin gradients, and also to learn about what the tests that we would order during peritoneal tapping and the reasons behind it. And likewise for pleural tapping, you also need to learn about how to interpret the pleural fluid analysis, and also you need to learn about what are the clinical utilities of these light criteria, is implication as well as the limitations by all these criteria. Just to spend one slide to talk about the serum acetic albumin gradients, I think you can read about it. Basically, how do we calculate the gradient? It basically is just serum albumin concentrations minus the acetic albumin concentration, then you will derive the SAAG. And the interpretation of it will be as highlighted in these tables on the right upper corner. Finally, we come to the last sections of the discussion, which is about the management. And before I delve into that, I would just like to mention that in examination as well in clinical practice, you always get two groups of patients. The first group will be the group of patients who are acutely ill, those in your emergency department or those who have been hospitalized, admitted to the ward. On the other hand, the other group of the patients will be stable patients who come from their regular clinic visit. Or sometimes this group of patients, for the sake of examination, they will be recalled from home just to for you to take history as an examine, as well as to discuss this case during the examinations. But nonetheless, I to try to give you an overview on how to manage these acutely ill patients, because I think in practice these are the types of patients that warrants most of our attentions. This is just one of the templates that I find it quite useful, especially for patients that are acutely ill. So always we start off with the acute management and stabilization of the patients. We will start off with the primary survey. You check the airway, breathing, circulations, then you institute life-saving therapies or acute therapies. You stabilize them before admitting them to the ward. During the stabilization or optimization of care phase, most of the time will be multidisciplinary approach, and then we will focus on the medical therapies like the supplementary oxygens, hydrations, nutrition, antibiotics, disease-specific therapy, etc., and also rehabilitations. For instance, like physiotherapy, occupational therapy, dietitians, involvement, etc. And continuations or optimization of medical therapies. Last but not least, we will always talk about discharge plan. Where would the patient be followed up? Would the patient need a short review upon discharge? And also a long-term follow-up for patients with chronic diseases. But overall, this does give you some ideas on how do we strategize or how do we plan our care for our patients. So as practicing doctors, you can take what can be applied in your clinical scenario and discard what is not applicable in your settings. Overall, I think this forms the basics of the management for our hospitalized patients. In a nutshell, I would like to summarize the take-home message for this CME. I hope at this point you understand that it's very important for us to have a clear understanding on how to take a detailed and a complete medical histories, and also you have learned how to formulate your differential diagnosis and also how to justify the investigations that you will routinely order for our patients, and also how to manage acute versus chronic cases, and also how to outline our plans depends on the patient is whether in the acute setting or in the chronic settings, and also how to differentiate pharmacological versus non-pharmacological management for our patients. And also like to drive home that I think each of us will need a credible medical textbook, references, or even CPGs during our learning process. Thank you. I hope you have learned a thing or two about these lectures. If I have enough time in the future, I will do another CME on CX, also known as a clinical evaluation exercise. Thank you for your time and have a nice day, everyone.